Hi, my name is Dr. Don Buford. I'm an orthopedic surgeon based in Dallas, Texas. The title of this presentation is Slap Repair and Throwers. This was first presented at the 2022 FEMICOT International Meeting. These are my disclosures. I'd like to start by telling the story of where slap lesions really began. James Andrews first described labral tears in throwers in 1985, but it wasn't until 1990 that Dr. Steven Schneider and his partners formally described the first 4 types of slap lesions. The initial treatment for slap lesions was the simplest, debridement. In 1995, these 2 authors reported on their treatment of 30 baseball players with debridement of their type 2 slap lesions. The results were not overwhelmingly positive, but they were encouraging. 54% had good or excellent results, and among the pro baseball players, 74% had good or excellent results. In 2000, we published in Techniques in Shoulder and Elbow Surgery on our results from treating these type 2 slap lesions with a double-loaded suture anchor repair, as seen on the right side of this slide. Our 3-year follow-up results were pretty good. 79% of our patients had good or excellent results. However, when we start to look at overhead athletes specifically, the results did not seem as positive. In this paper, the overall return to sports rate for overhead athletes was only 70%. When you looked at a subset of professional athletes, that return to play number dropped down to 60%. So now we have a surgery, specifically slap repair, that is not getting us the results that most of us would want for our athletes. Just this year, there was a publication looking at slap repair in professional baseball players, and they were able to quantify the difference between pitchers and other position players. Pitchers were noted to have a significantly lower return to play and a return to previous performance, with a return to play that averaged about 70% and a return to previous performance that was only about 55%. Position players had a much better return to play and return to previous performance, with about a 91% return to play and a 77 to 78% return to previous performance. So here, pitchers are doing significantly worse than other positions in the sport of baseball. As a result of these reports of less than satisfying return to play and return to previous performance in throwers, many surgeons have started to look at other potential surgical options, and biceps tenodesis has been the primary option that surgeons have pivoted to try and get our patients back to the same level of performance. In this 2021 review and meta-analysis, the authors concluded that the results of biceps tenodesis compared to slap repair were not inferior. So this was one of the early meta-analyses that showed that with biceps tenodesis, whether it was suprapectoral or subpectoral, that these athletes were getting back to sport at least at the same rate as slap repair. And so now further study was needed to determine if we can do even better than this. Just this year, Anthony Romeo and his group published on open subpectoral biceps tenodesis. This is a relatively small study with 14 professional baseball players, but they did note that they got 86% of these players back to sport after a biceps tenodesis. However, there was still this problem that only 50% returned to the same level. Now, here is a larger study from Dr. Jazraoui and his colleagues. This study has 44 overhead athletes. The mean age is 35 years old. In this study, 82% of their patients returned to play. 60% returned to the same level. And on average, it took somewhere between 8 and 9 months to return to play after biceps tenodesis for isolated slap tears. This is one of the best studies we currently have in the literature on this topic. This is from Brian Waterman and Dr. Romeo and their colleagues, and they noted a high rate of return to activity with a subpectoral biceps tenodesis for a type 2 slap tear. 81% of their patients returned to the previous level of play, and they're able to get them back at 4 months, which is about twice as fast as some of the other reports in the literature. And again, this is with a specific subpectoral biceps tenodesis technique. And here's another study that I think is one of the best too in the literature on this topic. In this study, 103 patients were followed. The average age was 25 years old. This study has 5-year follow-up. And what they found was no significant difference between the treatment groups, between arthroscopic repair or subpectoral biceps tenodesis in any of the functional outcome measures that they looked at. What they did find, however, was a trend towards more revisions in the arthroscopic repair patient cohort. So what are some take-home pearls? It is pretty clear from multiple authors that subpectoral biceps tenodesis is a valid treatment option in throwing athletes down to age 25. In throwers under 30, there is a definite trend towards higher revisions with slap repair versus biceps tenodesis, but all other outcome measures seem to be very similar. Take-home pearl number 3. If there is rotator cuff pathology, especially if our patients are getting older and still trying to compete, a biceps tenodesis seems to give better clinical outcomes than a slap repair for a type 2 slap lesion. So if the rotator cuff is abnormal, consider a tenodesis instead of a repair. Take-home pearl number 4. This really relates to informed consent and is the discussion I have with my patients that have these type 2 slap lesions and are throwing athletes. What I tell them is in about 8 months, I can get about 80% of our patients back to throwing with either a repair or a biceps tenodesis. If they have rotator cuff pathology, that tilts the scales towards a biceps tenodesis. And really, if they are younger, there is a trend towards fewer revisions if we do a biceps tenodesis as well. And so for those reasons, I tend to do more biceps tenodeses than arthroscopic repairs for type 2 slap lesions in throwing athletes. Thank you very much.